Family violence is any behaviour within a relationship that's a family relationship or a domestic relationship that causes physical, psychological or sexual harm.
We all deserve to feel safe in our environment, in our relationships. And if somebody does not feel safe, then there is violence.
Family violence is a whole set of behaviours that really relate to having coercive control over another person.
Coercive control occurs when the perpetrator has controlling behaviours over the survivor. And what happens in many cases that they'll isolate the survivor from their friends and family. They might do things like stop them from working. They might do things like track their emails to see who they've been corresponding with, who they've been phoning, who they've been texting, that sort of thing.
It can take lots of different forms. It can be physical, it can be emotional, it can be sexual, it can be financial, or it can be social.
Technology abuse is becoming more and more common. And, using things like phones, tracking devices, on the iPhone, Find My iPhone to track people so that they know where the survivor is at all times. And even things like listening devices and recording devices and things like that can be used in terms of technology abuse as well.
I think that's the main thing. It's not about anger. It's not about the man getting angry. We all get angry at various times and we all act in different ways when we get angry. Some people yell, some people scream, some people go into themselves. But family violence isn't about the man getting angry at the woman. It's about the man acting out and using his power to scare and intimidate.
But we know that abuse is beyond physical, and it's really taken us quite a few years to give labels to what we consider to be not right, to be abusive.
Certainly relationships don't start out as being controlling. They start out as being loving, respectful, mutually respectful. But then things turn for the victim to start having to do more for the perpetrator, to be more controlled, have less choice, have more autonomy taken away from them.
Sometimes patients say, well, look, the only reason my partner does this is because they care about me or they're looking out for me. And then exploring that a little bit further as a GP and being curious and asking the person, I think, well, how does that make you feel?
A typical case would be a woman who presents with ongoing depression that doesn't respond to counselling. You've sent the woman off for the usual mental health care plan. They've seen a psychologist and nothing gets better. They've been tried on various antidepressants and nothing gets better. And the reason nothing gets better is that they're continually, beating their head against a brick wall.
Survivors of family violence can present with chronic pain, for instance, chronic pelvic pain, chronic headaches. They may present with things like miscarriage or low birth weight babies, sexually transmitted infections.
The warning signs depends on who you're seeing. So if you're seeing a child, and it depends on if you're looking at physical signs or psychological signs, but essentially things like in children, bedwetting, difficulty sleeping, difficulty with emotional regulation, behaviours like pushing boundaries, mental health, so depression and anxiety, self-harming behaviours. They're all sort of psychological signs of family violence.
One of the traits of family violence is for the victim to be isolated from a lot of informal and formal supports. That includes really cutting access to friends and family, as well as cutting access to services.
It's also one of the indicators. If you've got an accompanying partner that comes every time to every visit, maybe they're just a partner who is really attentive, but you've got to just be asking the question: is it because they don't want the patient to be on their own? So what I always say to GPs is that we are in control of our own consulting room, and so we get to say who's in our room at any given time. And so just like you would with an adolescent and you'd get the parent to wait out in the waiting room, you can say, I always like to have a chat with my patients at some point on their own. Could you please go out and wait in the waiting room? You cannot ask the potential survivor, you cannot ask them if they are not on their own.
As both a GP and a GP psychotherapist, I would have patients and they'd be describing interpersonal issues, because that's the common reason people would come to see me. And they would be describing clearly coercive control, but they would make excuses for their partner. Or it's just he's a bit tired, or he, he's a bit stressed out. And, part of my role is to question that. It's like everybody deserves to have an equal voice in a relationship, and so, but it's not my way to do it in a judgmental way. I do it in a very curious way, and it's that there's a way of just gently, having people to go, maybe this isn't normal.
Yeah, it's very common. A lot of people don't realise they're being abused, and it can happen because perhaps in their family, it's what they've always witnessed. It's what they grew up with. So they see, for instance, the pushing and shoving, or calling people by particular names, or treating people in a particular way, especially things like coercive control. I mean, is that caring, or is it an abusive control situation? If it's what you've had modelled throughout your life, it may just seem normal, and you may not imagine that life could be anything else.
I deal with men who have been perpetrating violence. Often they will try and say how they've been subjected to violence, but when you actually dissect it, sometimes women do retaliate. So you can't just say that all men are awful and all women are never violent. It's never 100%, but it's that imbalance of power that's so significant. So even when there has been some fighting both ways, it's usually very biased in that the woman is scared of the man and the man is not scared of the woman.
Pregnancy is a key time where we get concerned about the possibility of family violence, because we know that it's a time that often family violence both starts and escalates where it's already been occurring previously. So we know that it's a good idea to be screening all women antenatally, so all women who are pregnant, about the possibility of family violence. So we should be asking, and in general practice, we actually see a lot of women antenatally, particularly in that first trimester, maybe early second trimester stage. So we should be asking all these women about the possibility of family violence. It is a risky stage. We think that family violence increases during pregnancy for several reasons, but one in particular is that the perpetrator may be becoming jealous of the fact that the survivor now is thinking about someone else and not just about the perpetrator.
The first thing is to recognise family violence. And what I find is, for a lot of people, we don't. And, there's some scary stats that it says 1 in 10 women attending a general practice have experienced family violence in 12 months. For a full-time GP, that would be 5 patients a week.
Doctors should respond empathetically, and we suggest the LIVES response, which comes from the World Health Organization. So LIVES stands for L for listen, so to listen non-judgmentally and believing the patient in front of you. I for inquiring about their needs and concerns. V for validating your patient. So that's a validating statement. So to encourage them about the fact that it is not their fault that this is happening to them, to let them know that what is happening to them is not okay. E is for enhancing safety. So that's to do a risk assessment and safety planning. And S is for support. So that may be to offer a referral to family violence services, but it definitely means continued support from you, the GP, because you've started to, you've got a relationship with your patient.
We often refer to a lot of victim survivors as women, and women are a large proportion of victim survivors, but there are people who identify as men and non-binary patients as well. I think there's large proportions that are highly represented. So, for example, Aboriginal and Torres Strait Islander people are highly represented in victim survivors of family violence. Culturally and linguistically diverse people are also heavily represented as well, and LGBTQIA populations, people tend to be highly represented as well.
We should be curious and think, well, what else is going on in their life? To get out of thinking of just the physical side of things, and perhaps even beyond the mental side of things, and onto the social side. So what is going on in your life? What's it like living in your house? Who do you live with? What is your everyday life like? Are you happy where you are? Tell me about your relationships. Tell me about the relationship with your partner, your children, your family, other people, the workplace. And that's when we can just ask in a non-judgmental, safe, confidential way. It's very important that we maintain a sense of safety by promising that everything will be confidential unless there's a very strong and uncommon reason why we need for their safety to break that confidentiality.
I think it's very important to document. I try and take actual quotes from the woman and put them down. So I'll put them in inverted commas to show that they're quotes of what the woman has said, or to the best of my ability. I can touch type, so I can generally do that. If there's any bruises, I'll take out my phone with her permission and take a photo and upload it to the file. Then you have to be very careful to delete it from your phone. And if it's saved up into the cloud, make sure it's deleted from the cloud, because you don't want anything happening there. And you need to be aware that the notes can be subpoenaed. So you need to make sure that they always have to be an accurate record. I always ask the woman during the consultation how much of what we've talked about can be shared with the man. And again, we get one of three answers. Sometimes the answer will be nothing. Don't say one word. If he knows I've been in here talking about this, then I'm in big risk, and he will abuse me. He will tell me off. Sometimes they'll say, here, write down his number, and I'll say, here's his number, give him a ring. Maybe he'll listen to you, because he certainly won't listen to me. And then sometimes they'll say, look, you can tell him that we're having some issues, you can tell him that things aren't quite right, but don't tell him that I've said that he's been violent, but tell him that we've got some marital problems. So I write that down on the notes, and I'll try and get it exactly as the woman said. Then I'll turn my screen around and I'll show it to the woman, and I say, is this correct? Because this is actually what's going to put her at risk or keep her safe. Because if I stuff up on that and I see him and I know I've made some notes and I open up the record and refer to it, I have to make sure that this is accurate.
So, for example, if you are in a general practice where the perpetrator is being looked after by a different GP and you're aware of that woman's in a family violent relationship, if you feel it's going to benefit, you can let that GP know who's looking after the perpetrator. Now, we've got to be really careful. This is where the training has to be so well taught, because we wouldn't want the GP of the perpetrator to go, hey, I hear you're doing this. But it's more he knows about it, and we can just kind of segue, just kind of throw into the concept, how are you going? You're having, how's your stress levels? I like to find out how everybody's going. And you might, if he's got a good relationship, it may be that the perpetrator says, I'm really stressed and I'm not coping and I'm drinking a lot of alcohol, and we can help that way.
I think the main thing is for GPs to be having family violence in the back of their heads whenever they see a patient, particularly when they see female patients, because it is more common in females, but any patient that has indicators that you think you need to be asking about. So I think it's just a matter of keeping it in the back of your head, being aware that it's common. Globally, 1 in 3 women are subjected to family violence at some stage in their lives. In Australia, it's probably 1 in 4.
One of the things is create a safety plan, and we need to think about when are you planning to leave and how will you leave and who's on your support service, and things, practical things like if you need to get your identity documents, if you need to get money, like I've had some patients where they take out $5-10 at the supermarket every time they go, so they can be gathering, money, or they open up another account. So and it's awful to think that we have to do that, but we want it to be a success. And again, we want to empower the client.
There are several things that we look for to determine whether a survivor is at increased risk. Some of these things, and these are all about the behaviour of the perpetrator. So an increase in severity and frequency of violence makes us concerned. A history of choking, strangulation makes us concerned because there is a 7 times increased risk of a survivor dying if that's occurred. If there's been threats to kill, there's a 15 times increased risk of dying if there's been threats to kill. Being pregnant is a risky time. The most risk time is when you are about to leave or in the 3 months after you have just left a relationship. That's the time that you are actually at most risk of dying as a survivor. And I think it's really important to remember that there is unfortunately a mortality rate when it comes to family violence, and that it is important to take it very seriously, and that there is potentially a risk of something happening. So assessing risk is really important.
GPs are human too, and we spend a lot of time managing difficulties in our practice. Relationship issues are probably one of the most difficult things that we do practice, and violence and abuse is very distressing for us and for the people in our clinic.
Family violence services require their staff to have specific supervision to be able to help maintain their own sensibilities, maintain a gap between the professional selves and personal selves. And it's highly recommended with other professionals such as AOD workers or mental health workers to do much the same.
Really, really important that we acknowledge that this work is incredibly complex and emotionally draining for GPs. And vicarious trauma is really common if you have even 1 or 2 patients who you're supporting. And if you're not sure what to do, so I would always encourage you, contact 1-800-RESPECT first. Now, that's the number we give for our patients, but they've also got a great resource for any health professional who's not sure what to do. In Victoria, also Orange Door is another one that we could contact. There's a lot of training now being offered for GPs, so through RACGP, but also Safer Families have some excellent online modules. Or if you know of GPs who have more expertise, don't be afraid to go and reach out. And because one of the most important things is you don't do this alone, because that's where you end up taking it home with you, and we don't want that to happen. Yeah.